welcome to the September edition of Alfred Health's Journal Club. I'm Conor O'Flynn, the Alfred Emergency Department Senior Registrar for Research, and today I'm joined by the Academic Director for the Alfred Emergency and Trauma Centre, Professor Peter Cameron, as well as one of the Directors of Emergency Medicine Training and, more importantly, my Educational Supervisor, Dr. Dave McCreary. Today we've got
everything on this.
As long as I can send you a Kaizen for it, I don't mind. Today we have 3 papers for discussion that were discussed at our in-person journal club the other day. First up, we're looking at regional anaesthesia in the emergency department with the serratus anterior plane blocks for early rib fracture pain management, which, as they always do, has a snazzy little title, the SABRE randomized control trial, which was published in the Journal of the American Medical Association Surgery in May of this year. Second, we have the retrospective comparison of upper and lower extremity intraosseous access during out-of-hospital cardiac arrest resuscitation from pre-hospital emergency care in March 24. And lastly, upon the recommendation of one of our registrars, we'll be looking at challenging the dogma of nitrates in right ventricular myocardial infarctions with adverse events from nitrate administration during right ventricular myocardial infarction, a systematic review and meta-analysis, which was published online first in the EMJ in 2022.
Alrighty, so do you want to tell us about SABRE? Just because I like saying SABRE. It sounds like a strong trial just from the name.
Well, we'll see, won't we?
Paper 1.
So the SABRE trial was an open-label, multi-centre RCT across 8 sites in Australia, with the intervention arm receiving a single-shot serratus anterior plane block, in addition to standard care for rib fractures, as defined and determined by each hospital, whilst the control arm received standard care alone. Primary outcome was a meaningful reduction in pain score using a 0 to 10 scale. This was stated to be a greater than 2-point reduction or an absolute score of less than 4. Secondary outcomes included reduction in opioid usage at 4, 12, and 24 hours, as well as the incidence of pneumonia, hospital length of stay, and 30-day mortality. The study included 210 patients, and the results showed that 41.3% of the intervention arm and 19.6% of the control arm met the primary outcome. When we discussed this in person, we did a show of hands at the journal club to see who was actually regularly doing serratus anterior blocks, and it was clearly a minority. Do you think that based upon this paper, we should be doing more of them?
So this was a good discussion yesterday in the room because, as you say, there was a smattering of people who already do it. And I think this paper is very good for convincing people that already do it, that they're doing the right thing. If you were looking at the skeptics, and we can talk through the reasons why in a minute, but if you were trying to convince skeptics of it, I don't think that this paper would necessarily do it. That being said, my personal feeling is that it's not something that I do, but it's something that I want to start doing so that I can start to get a feel for it. What do you think, Peter?
Yeah, I think methodologically, there are obviously some big deficiencies in this trial, which is, I guess, is what we're looking at in the journal club. The thing about these types of procedures is that there are usually passionate people who undertake these trials and who participate in them. So the people who actually gave the block were also the ones who were assessing the degree of pain. They were also the ones that were assessing whether the patients got analgesia and so forth. So there is a huge bias in terms of observer assessments, which could have, I admit that it's difficult with these sorts of studies to do double-blinded trials, but it's not that hard to do blinded assessments, which for some reason they didn't do, which would have made it a lot more robust. In saying that, it sort of makes sense if it's relatively easy to do and if it cuts down opioid use by a large amount in the first 24 hours, then, it's hard to argue against. The other thing that was obvious was it took 4 hours or so for them to actually do it, which I think is a long time for someone who's got serious pain. and I'm not sure why it was so long. It might have taken that long to find someone who could do it. I don't know.
Is that particularly unrealistic though? If you think of, if you're doing a realistic trial of how emergency departments function, and 4 hours from the time that someone declares themselves as needing it, so you've got a CT that shows rib fractures or they've had a couple of doses of analgesia, is 4 hours really that unrealistic?
Are you in a centre of excellence or what, Dave?
Well, you know how I feel about our centre, but if we're trying to, look at this for emergency departments across Australia or worldwide, is 4 hours that unrealistic?
Realistically, they should get a CT within a couple of hours. And I would have thought once you had the CT and had delineated the lesions, then that would be a reasonable time to do the block.
Prof, you said that with 2 hours, you'd be hoping that everyone's had their CT and then you can be in the position to make a decision. But definitely worldwide, my experience is not that everyone's seen and that decision's made in 2 hours. And occasionally, even where we work, we're picking up people who have still got significant pain when they're in ESU on the next sort of 10, 12 hours later. So, I mean, ideally, yes, we'd have them CT'd and treated within 4 hours for the block, but I can understand how the numbers are where they are for this paper.
And the other thing was not all of them actually had rib fractures, did they? There were it was a very heterogeneous group.
Yeah, I wondered about that because I suppose we do have patients that have rib fractures that you can't see on CT, though they don't tend to be the ones that have so much pain that they require admission and blocks and things like that. But I'm just wondering if those were maybe those patients that they were just, because we've all seen them, patients where you're like, clinically you've got a rib fracture, but it's just not radiologically apparent. The question I had, and I raised it yesterday as well, is, and I know that Connor, you've mentioned that they talk about this in their ethics side of the paper, but why there was no placebo for this trial? Because it just feels like it seems to me like this is a sign of bias in the study design in the first place, because there was a couple of things. There was the lack of placebo, and the fact that the procedure that they were testing was also considered to be the rescue analgesia for failure in the control group. And that to me says that you've already decided what the benefit is of this treatment and you're not truly assessing it.
But Dave, in terms of the ethics, sham physical procedures are very hard to get through. There have been occasions on which they've actually done open operations and not actually done the operation. But these days it's very hard to get it through an ethics committee to actually do something that is of no benefit to the patient.
Certainly, and I can picture if you're applying to ethics, and so we already think this block's great, so we're not going to allow a placebo for that. But this isn't an operation. This would just be, you could do a subdermal injection of some saline, and technically that, with an ultrasound probe on the patient, that's probably enough of a sham procedure.
I think anything that's physical will be very hard to get through an ethics committee.
But then that does, because my concern is that then changes, because as you've said, they weren't blinded to the assessment later on. So, and they're not blinded when it comes to the treatment pathway. So they're less likely to be offered opiates because sure, you had that block. You don't need a dose of endone, do you? Because you've had that block. And so to me, that really just puts so much bias into the whole paper that it just really ruins it for me.
I agree. But at the same time, but even if they'd done, independent blinded observers, that would have made a big difference to the robustness. Anyway, it's sort of, as you say, confirmation for the believers, and still leaves the door open for those people that wish not to do it.
Connor, any take-homes from the registrar group or anything else that we mentioned on the day yesterday?
I think for us, we see it as a fancy new procedure that we can get our mitts on. And I think it's the same with all regional anaesthesia and all things that are slightly out of our scope of practice that we want to bring in. That we want to do them And I think for a lot of people in the room, they were like, oh, yeah, we've got justification to push for getting upskilled in this. And yeah, I've seen a few. They're not something that's part of what I can do, but I would like to do them. I think that was the main takeaway. It wasn't, if anything, the everything that was said after you can do them was, oh, that's pretty good. I think a lot of it washed over our heads.
Yeah, I think it's definitely something that I want to see in our armamentariums. I want to play with it a bit and see what the effect is on patients myself. I'm certainly not saying that it's a procedure that I don't think has benefit. I just think from an EBM side of things, they could have maybe approached things differently to make it more convincing, to convince the skeptics. Alrighty. What was our second paper, Connor?
Paper 2.
Our second paper was a retrospective study out of the States comparing the outcomes of out-of-hospital cardiac arrest who received IOs in either the upper or lower extremity during resuscitation. Largely, this boiled down to proximal humerus versus proximal tibia. The primary outcome was return of spontaneous circulation, and the secondary outcomes were survival to hospital discharge and survival to discharge home. The study included just over 155,000 patients from the ESO Data Collaborative Public Use Research datasets, with 76% receiving their first successful IO access as determined by the practitioner in the lower extremity and 24% in the upper extremity. The results showed that the upper extremity IO access was associated with increased odds of ROSC, increased odds of survival to discharge, and increased odds of survival to discharge home. The theory here is that the humeral head, I guess, is closer to the heart, and that when compared to tibial IOs, and this could lead to a decrease in the amount of time it takes to achieve peak serum concentration for the medications. I'm very much more comfortable doing a tibial than I am a humeral. And I felt that in the room yesterday or the day before, I think that was shared. And I think that when we were talking about it, we spoke about practical barriers to the humeral IO during resuscitation.
Yeah, and I think that's a key point here, isn't it? And they'd make that point in the study. So when they were doing this, it's obviously retrospective. Association does not equal causation, etc. I think a key point is that they're saying this is the first successful IO access was largely in the tibial region. And one of the points that they make is that, yes, the tibial region is more reliable and generally an area of more comfort for a larger proportion of providers. And so they wondered whether the providers that got their first successful attempt being a humeral IO, does that mean they're a more experienced EMS group to begin with, and so that could have ongoing effects to the rest of your resuscitation. And that's one of the limitations of a retrospective paper. What did you think, Peter?
Yeah, like there's about 500 holes you could drive a truck through in this study, but it is a hypothesis generating study. And, the first question is, I guess, do we actually know that any of the ALS drugs make any difference to outcome? And there's evidence from the paramedic trial that it does improve ROSC. Whether it improves a good outcome is another question, but certainly it improves ROSC. And this, if in fact the theory that increased bioavailability earlier results in better ROSC and humeral intraosseous enables that, then I guess that's worthwhile knowing. In terms of the methodology of the study, though, the problem, as you mentioned, with this sort of retrospective data set, but it's retrospectively analysing a data set, is that what we don't know is the sequence of events. So, and as Dave mentioned, the experience of the providers. So I think most people, as evidenced by the room yesterday, most people would find the tibia easier. And what we don't know is whether many of the patients, for example, they tried the humerus and then went for the tibia, because that would show as a tibial intraosseous rather than a humeral. And the ones where they failed, they might not have got an intraosseous in anywhere. I don't know, but the point is that we only know those where they successfully got an intraosseous in, which might be all those that were easy and with skilled practitioners, which would create a huge bias in terms of ROSC. So they do mention that in the limitations. So we've got two things. One, does it actually matter? Two, the reason, the bias caused by the reason for the person having a humeral intraosseous. Nevertheless, there is, laboratory evidence that putting a intraosseous in the humerus results in earlier bioavailability of drugs. So, there's a theoretical reason behind it. What I'd like to see is a prospective study, maybe a step wedge design, where you actually introduce a protocol which says try intraosseous first, and then see whether that has an impact on ROSC using a whole of service approach, because it'll be very difficult alternating, for example, as per an RCT, a normal RCT. So something like a step wedge design would be the way to do it, with a change in protocol to prioritise humeral head when as your first intraosseous.
Well, it sounds like I don't know if they're doing it as a step wedge, but it sounds like you might get your wish. You mentioned the paramedic trial earlier, which was the adrenaline versus placebo trial, but the paramedic 3 trial is going to be IV versus IO access for out of hospital cardiac arrest patients. And they also mentioned that there's another one, the IV-IO trial, that will randomize patients to either of those, but will also sub-randomize them into arm versus leg, so humeral versus tibial. So we may get some actual randomized controlled trial answers on this in the. But
how many patients will they have?
I haven't looked into the protocols to see.
I mean, you're going to need huge numbers. This was, the difference in outcomes was tiny.
It was like a 2% improvement, I think they got. And this is over, hundreds of thousands of patients?
155,000.
Yeah.
You can't do an RCT with it.
Well, that's the thing, because even when you look at the paramedic 2 trial, which was very impressive, but for doing adrenaline versus placebo, and I think they got 8,000 or something like that, which for that study is really impressive. Doing an RCT of that number is going to be very difficult to see an improvement. I think one of the things worth mentioning is, as Connor said in Journal Club, we probably don't do IO access enough in centers like the Alfred, because we have other access points, and we would need it mostly in trauma patients who we do subclavian MAC lines and things like that on. But if you don't train for it, you'll never be able to put it in. And so we do teach on our procedures courses, we teach humeral IO access, because obviously in a trauma patient we would want to be avoiding the tibia. And I think if you're listening to this and thinking, oh well, I know how to do tibial access, so I'm happy enough with that, the difference isn't that big, I would say there's at least a reason here to go and learn your humeral, and part of being advanced practitioners being able to do several methods, because their tibias may not be an option, and the humerus does take a little bit more of a skill set to do, so it's worth practicing before you need it. And certainly, there's no reason not to use it as your first line if you can get to it, bearing in mind the arms then need to move around, particularly in trauma patients.
And I think, certainly in trauma patients, a smashed pelvis, you wouldn't want to put in a tibial intraosseous. So it's a useful skill to have.
And also far more exciting than putting in a cannula.
Everybody, first thing they do when they pick up the Easy IO, that's why the battery keeps running out.
You can't replace them either. Easy IO have got it absolutely made. You have to just buy a whole new kit It's a great
It's
model.
A very good business plan. Okay, let's have our last controversial, dogmalizing, who knows, study.
Paper 3.
Our third paper is a systematic review and meta-analysis of the adverse events associated with nitrate administration during right ventricular myocardial infarction. The review included 5 studies totaling 1,113 patients with a variety of different nitrates, including GTN, nitrous oxide, and SNP, whilst the meta-analysis only included 2 of these studies, one of which came from grey literature, but both focusing on sublingual GTN administration. The results from the meta-analysis showed that there was no statistically significant difference in adverse events for RVMI versus other infarctions. Alongside this, the majority of adverse events were minor, for example, transient hypotension that responded well to fluid challenges. Based upon this, the researchers concluded, albeit with a very low certainty of evidence, that the established guidelines by the AHA and ESC regarding the contraindications for nitrates in RVMI are not supported by current evidence. This study was brought to Journal Club by one of our reggers, and during Journal Club, a different reg, who will remain nameless, expressed concerns about the meta-analysis containing a non-peer-reviewed study. Do you think we should have major concerns about how heavily weighted a piece of grey literature was in this?
It depends a bit on what you mean by grey literature. I don't think study results have to go through peer review to be included in a meta-analysis. What's important is if the primary data is available to the researchers to do a meta-analysis. That what is actually worse is if a study has been done with a reasonable number of patients and ignored because it hasn't been published or doesn't fit some arbitrary criteria, then that data, it's almost unethical not to use those data. So I think, and that's brought up in many reviews of systematic reviews, that quite often they don't include a whole lot of, say, drug company studies that have never been published. But the drug company chose not to publish them because they weren't positive. So it is important when you're doing a systematic review to look for papers that or studies that haven't been published. And if you can gain access to the primary data, then that's valuable.
Yeah. I think that's a good point. Like, to me, it's a sign of a good meta-analysis or a good systematic review that they went to the effort of trying to find the data. And yes, ideally you would want it to be peer-reviewed, though I suppose the peer review isn't just looking at the raw data, it's looking at how the authors have interpreted it, what their methods were for getting the data and things like that. And at least this was published as a abstract, so that some form of their methodology has had some form of peer review, but we all know the limitations of peer review in general as well. I think the main point we were saying in the Journal Club, though, was because there's so few papers that can be meta-analyzed in this, the weight of the one that wasn't peer-reviewed was 58.69%, which is something worth considering when you're looking at the effect that it has. But a really interesting point for discussion. The question is this going to change our practice? And the question I had to the Regis in the room, because this is a bit of background, if you're not familiar with this, is it's exam fodder. UK, Australia, wherever, whether or not to give nitrates to an inferior and then query right ventricular MI is easy exam trap for them to lay for you. And I've laid that trap before in questions for people. So the question is, if you had your exams tomorrow, what would you say? What would your answer be?
Well, I guess I am currently prepping for the FR Chem ones. So if it's in an SBA, I'm answering in line with the guidelines. If it's at the OSCE, I'll probably say what's in the guidelines, but then I'll justify my decision one way or another, because realistically, I don't think there's actually a big place where you can criticize either way at this point. I think it would be case dependent.
Yeah.
But if it's an NSPA, I'm reciting exactly what they've said for me to learn.
Yeah, no, I think that's fair. And then when it comes to applying it to our clinical practice, there was a couple of questions raised. There was, obviously this suggesting that it's maybe safer than we've constantly been schooled, but also what's the benefit of it? Because there's a big question mark about the benefit of nitrates in the first place. And we're talking about patients that are having, probably most of these will be STEMIs. There's a very well established treatment for STEMIs. And nitrates isn't necessarily it. It's getting them to the cath lab or thrombolizing them. So it's just, remembering that. On the other side of that, though, if you do have a patient that you feel like you need to give nitrates to, if they've got a reasonable blood pressure to begin with and you're prepared for them to have that transient dip, there's enough here to suggest that, fluid bolus and a bit of Trendelenburg positioning could correct it. And so it's not necessarily the life and death thing that has been touted previously. What about you, Peter? What are you doing with your next RVMI? Sending it straight.
Well, as you say, I mean, what are you giving it for? Are you giving it for analgesia, or are you giving it to clear the artery, or
it's
decrease the afterload?
Yeah.
I mean, there's no evidence that it makes any difference to the actual lesion. Whether it's harmful for circulation or not is not clear. And as for analgesia, there are probably better agents for analgesia than nitrates. So if the next inferior STEMI that comes in, I'll be taking straight to the cath lab and maybe giving them some analgesia. I wouldn't be giving them nitrates. One of the other interesting things that was brought up in this study was the original paper, which was 89, I think, or that's
89, I think.
Yeah. They didn't actually state the dose of nitrates. So we've really got no idea. Like, they could have been giving 2 or 3 times what we would normally give.
Yeah.
So it's not clear. I remember in the old days we were fairly liberal with the nitrates. So yeah, it's and we used to keep dialing it up until we got a result, in terms of stopping. We had to stop the pain with nitrates. That was the mantra. So it could be that some of these people got quite big doses. So yeah, I'm not sure how useful the paper is really, because even in a rural setting, the first thing you would do would be to thrombolize, and then you'd give them analgesia.
I think it's the main use of this is that it's interesting to shine a light, though, on dogma that gets repeated over and over again. That's how it becomes dogma. When it comes from, the most interesting part to me is that it comes from a study of something like 50 people, where with unknown doses via multiple routes, where the only outcome they looked at was a systolic drop of more than 30. But if that's gone from 200 to 170, who cares? And so, yes, now we know, and because we've got so much better treatments now than when these resuscitation guidelines were formed, it's probably a moot point. But from a purely academic side of things, it's interesting to see where those dogma can come from, and where it goes to, and how difficult it can be to undo it.
The other thing is, even without giving the patient anything, some of these patients suddenly just drop their blood pressure. So again, you need to be very careful, and the patients who get more pain and therefore get more nitrates are the ones who are going to drop their blood pressure. So it's, with all these studies, if they're not well controlled, it is very difficult to interpret.
But I don't think there's going to be any need for it to become a randomized controlled trial, because, as we've said ad nauseum here, it's not a treatment that really matters too much. Certainly to us in Australia, where you've got easy access to thrombolysis and and to PCI, primary PCI, which is certainly what I would want when I have my RVMI.
This is more a debate that you can have as you're wheeling the patient up to PCI that's going to have no consequence, and you can be stared at by the cardiologist being like, do whatever you want, I don't mind.
Yes.
We're going to PCI.
Yes, certainly not a hill to die on.
Yeah.
Or not a hill for your patient to die on.
Yeah, I think
don't take them to PCI. I've just got the nitrates ready to go.
I've got high dose SNP. Please give it a chance.
I think for me, every paper I read, it's not just about the actual clinical conclusion. I think papers, there's always something to learn from them, and for me, it's just seeing the original paper highlighted and being able to pick that apart. And anytime you read a paper, there's actually a lot in the background and there's a lot in the discussion that you can just pick up secondary learning points from.